Good morning. I'm JoAnn Pinkerton. I'm Executive Director for the North American Menopause Society and Professor of Obstetrics and Gynecology at the University of Virginia in Charlottesville. And we are here in Philadelphia at the 2017 North American Menopause Society annual meeting. And I have the privilege in just a few hours of talking about our new hormone therapy position statement. It was just released. It's been endorsed by over 30 different societies. And the key take-home message is that for women who are under 60 or within 10 years of menopause, hormone therapy is safe and effective for the relief of hot flushes, night sweats, improving sleep, and also for the prevention of bone loss and fracture in women that are at high risk. The experts all agreed on that. The experts also agreed that the group of women who shouldn't be offered hormone therapy, you shouldn't initiate hormone therapy in women who are over 60 and certainly over 70 or further than 10 years from menopause because they have higher absolute risks of heart disease and blood clots and stroke and dementia, and we might be increasing those risks. We also looked at some special populations. So for example, we don't think that there has to be a hard stop date, that you have to stop hormones at 60 or 65, but instead individualize. Is there a reason to continue it? Can you lower the risks? Can you have a conversation each year about their new health risks and whether or not it's appropriate to continue hormone therapy? And at the other end of the spectrum, for those women who have early surgical menopause or primary ovarian insufficiency, we now know that there's health risks associated with the loss of estrogen, that there's more heart disease and osteoporosis and dementia, Parkinson's, eye issues, and that those women should be offered hormone therapy at least until the average age of menopause, and then we can consider whether or not to continue it. So those were two really special populations that we wanted to make sure were covered in our hormone therapy position statement. And then we looked at the effect on many different types of, the heart and the breast and the bone. Breast is really complex because hormone therapy, estrogen by itself seems to decrease the risk of breast cancer. Estrogen and synthetic progestin seems to increase the risk. So thinking about ways to individualize therapy for women who might be at higher risk for breast cancer or might be at higher risk for the metabolic syndrome, lower doses, consider transdermal therapies, consider some of the newer options that don't even continue or add the progestin back in. These are all newer options that we have for women. And I think we really want to change the conversation. We want to take away the fear of hormone therapy and say that for women who are close to menopause and having these menopausal symptoms, that hormone therapy is actually safe and effective. And if you have just vaginal symptoms, think about just using vaginal therapy. And if you have women who are at elevated risk for fatty liver or metabolic syndrome, think about the transdermal therapy, think about lowering doses as women age, and have that conversation each year about what you want, what the woman wants to get out of the therapy, how to minimize the risks. And we also made a point that we don't recommend compounded hormone therapy, that there are unique risks associated with compounding, including over or under dosing, contaminants, and so we strongly encourage the use of FDA-approved therapies, including bioidentical therapies. And once again, we have so many options for women. I appreciate you taking time with me today and hope that you will come and attend one of our meetings.
Let it go, make my body go, take our bodies high.